All right. Good afternoon, everybody, and happy Valentine's Day. I'm going to give everybody a few minutes just to get all logged in. We are so excited to have everybody joining us today on this wonderful day. I know you're excited and anxious to get out of the office and go see and spend time with your loved ones, but thank you for taking a minute just to get a little more education in. You are in for a treat because you're going to meet and see one of the most wonderful ladies that I have had the pleasure to talk to, and you guys are going to learn so much today. Later on, you're going to meet our amazing partners over at HMR and Fox AE. My dear friend Patrick, who is going to moderate today, unfortunately, he is involved in that big snowstorm up north. So they have lost power. So he's asked me to take over moderating, and I am more than happy to do so. But let's hope Patrick gets his power back and he'll be back with us. Until then, we are just going to go ahead and jump right in and get started because we have a lot of great things that we're going to talk about today. And I hope that you will ask questions. You can put those in the Q&A box and I will keep an eye on them, and we will answer a lot of those when we have our breaks. But for now, let's go ahead and get started. I want to introduce our wonderful speaker today, Miss Theresa. She is a professional registered nurse and a certified legal and clinical nurse consultant with over 30 years of experience in healthcare, mental health treatment, as well as administration. And she holds a master's degree in human services and nursing with a focus on organizational leadership. And she's also board certified as a psychiatric and mental health nurse, nurse executive, advanced mental health counselor, as well as a legal nurse consultant. And she's so passionate about creating systems and empowering individuals and communities to achieve recovery, justice, and wellness. And I got very excited when I was talking to her and learning a little bit more about what she knows, because I have a whole bunch of ideas for future webinars that we're going to be doing together. She is a subject matter expert in behavioral health, as well as healthcare administration, substance use disorders, as well as recovery support and prevention. And I hope I'm saying this correctly, Theresa. Is it HSA?
SAMHSA, Substance
SAMHSA.
Abuse Mental Health Services Administration.
Perfect. That is a peer grant reviewer, and she evaluates comprehensive grant applications and provides sound and objective recommendations for funding decisions. So as a clinical consultant at the Higher Calling Foundation, which is a nonprofit organization that offers a lot of holistic and evidence-based programs and resources, she provides a lot of great education, as well as assessment and evaluation and research services to various stakeholders in the healthcare and the legal fields. Theresa, I'll be providing her information during this webinar as well. Highly suggest that you write it down and stay in touch with her. She leverages a lot of her skills in the systems management, as well as disaster preparedness, community relations, and process improvement to deliver quality and impactful outcomes in a variety of settings. I could go on. She's got the most incredible credentials. We are going to have an incredible webinar today. Theresa, it is such an honor to have you with us. And I hope everybody enjoys the webinar. I'm going to go ahead and pull up the slides. Feel free to get started. And then later I will bring in our amazing partners.
Okay, thank you so much. Thank you for having me. And I definitely think I need to condense that bio a little bit. Everybody can see the slides. I'm all right to get started. Hello?
Oh, yep. I'm going to go ahead and put this in a different presenter view real quick. Let's see. Give me 1 second, you guys. All right. All right, can everybody see this? Does it look okay?
It does to me.
All right, let's get started.
So again, good afternoon. Thanks for having me. And although I do have those credentials after my name, I am not technologically advanced. So I really appreciate your patience and Ginger, your assistance. We're going to talk today about the role of healthcare leadership and policy development and treatment planning in preventing the use of restraints. Generally, by the time a restraint case gets to me, they've already been implemented and an injury or death has occurred. So I wanted to focus more on the prevention. This first slide talks about the role of administrations and not necessarily administrators and not necessarily the people on the floor that are taking care of the patients in making sure that restraints are prevented. Because if the right training and policies precede the practices, generally you can prevent most restraint and seclusion incidents. Seclusion and restraints are dangerous and traumatic not only for the individual being restrained, but also for the staff that is implementing the technique. 50 to 150 individuals die as a result of seclusion and restraint practices every year. That's reported. In addition, surprisingly, there are very little structured reporting structures that accurately capture the amount of injury or death. And more importantly, a lot of the interventions that preceded the restraints are not reported. So we don't have the real picture. I'm being quiet right now just so you can read that. I often say this when an attorney calls, they're looking for the actual way that the patient was injured, but the patient gets injured long before the restraints are even brought out to use. SAMHSA further notes that with leadership, policy, and programmatic change, the use of seclusion and restraints can prevent it, and in some facilities has been eliminated. A lot of people in the psych industry won't talk about how some of the facilities have eliminated their use, because a lot of times it takes a lot of effort and time and money.
And Theresa, I'll move to the next slide. Just let me know.
Oh my goodness, I forgot. I've been changing them on my own. Okay.
It's okay.
I'm sorry. Are we on the AMA slide? There should be a slide with a siren on it.
Oh, hold on one second. I'm giving everybody just a minute to read that. Effective administration and clinical structure.
I'm sorry.
Oh, no, it's okay. All right. And now I'm on the next slide. In the United States each year, it is estimated that 50 to 150 individuals die as a result of seclusion. Should I go to the next one?
Yes, please.
Okay.
Are we at the treatment failure one?
Not yet. This one's the Cochrane collaboration.
Right.
Because,
and basically, like the GIF says, you have no idea of how bad it really is, because there's no mandatory reporting unless you get found out.
Mm-hmm. All right, now I'm on the report slide.
Again, there's market differences are noted with government and nonprofit hospital versus profit hospital. The standards are not the same.
Okay.
You can go to the next one.
Yep.
And this is the one that I really wanted to point out, that SAMHSA has emphasized the use of seclusion and restraint is a result of treatment failure, that the failure happens even before you put the restraints on the patients, much less what happens after. Next. Okay, we're all caught up. SAMHSA further notes that with leadership, policy, and programmatic change, the use of seclusion and restraint can be prevented, and in some facilities has been eliminated. It can and has been done. Next. I threw this slide in here to mention unanticipated discharges. I think it's important to include this here because, hang hang on. Facilities have a duty to mitigate this risk through education, communication, and safety planning. The opioid epidemic, which has been worsened by associated medical conditions such as endocarditis, and xylazine-related wounds, amputations, and death, has exploded. So just like restraints, proper planning is required beforehand to prevent patients from leaving treatment early. Next. Here, I just listed the actual standard of care, and that is that we use evidence-based practices, that we support open communication, that treatment occurs with the patient as a partner and not in a paternalistic environment, and that data and analysis and research are crucial to understand the factors influencing both behaviors and to develop better prevention strategies. We can go to the next one. A big part of preventing the use of restraints is using the trauma-informed approach. Recognizing and addressing past trauma can help predict and manage potential crisis situations. Next. Here, again, the trauma-informed approach, individualized care plans. The last case I had, a lot of the information and standard of care, the breach of standard of care that I was able to identify had to do with improper assessment, which led to improper treatment planning, which led to a patient losing his life ultimately, but it could have prevented if they had just addressed his cat right from the beginning. That's how individualized a care plan should be. We can go to the next one, which is a picture of my colleague, Margie, caught during a lunch break with pizza, a COVID mask, and a urine cup. Sometimes you don't have time to assess and plan because the workload is just too much. That's certainly a whole nother topic, but it's worth mentioning here because it certainly will be part of cases if they come up. Anyway, what are restraints? Both the Joint Commission, this is the next slide, both the Joint Commission and the Centers for Medicare and Medicaid Services have similar definitions of restraints, though with slight nuances. Both of them talk about the reduction of the ability of a patient to freely move his or her arms, legs, body, or head. Next one. Any manual method, physical or mechanical device, material, or equipment that immobilizes or reduces the ability of a patient to freely move his arms, legs, body, what I just read to you, but also throughout a unit. That is considered a restraint. All four side rails is considered a restraint. We'll get more into that later. We're at the freedom is peace of mind. A physical restraint is defined as any method or device, again. Both focus on the impact of patient mobility and freedom of movement. Both highlight the importance of identifying and planning for less restrictive alternatives before resorting to the restraints. We're to the teddy bear, Ginger. I wanted to mention here a therapeutic hold. This is used in adolescent and child environments. It's to provide comfort and support in de-escalation. It's the distinction is one of therapeutic versus coercive methods. The next one, Ginger. The imminent danger requirement is a vital safeguard for people in psychiatric facilities. It helps ensure that restraints are only used when absolutely necessary and in a way that minimizes harm and respects patient autonomy. However, it's important to note that this principle is often subjective and open to interpretation, leading to concerns about potential misuse or inconsistent application. Therefore, ongoing ethical, legal, and clinical dialogue is absolutely necessary to refine the use of restraints in psychiatric settings. Proper searches are a consideration. We can go to the next one, please. Imminent risk refers to the present impending risk of serious harm. This is not a hypothetical or potential risk. If you hear a staff member saying, "But he could," you cannot use restraints. But one that is happening now or about to happen. And the picture in this slide is a certificate I received because I was able to de-escalate a patient who had just pulled a sink off the wall. All of the water from the pipes were running into the administrative offices below. I was able to de-escalate the patient and get the entire linen cart into the room to top up the water while maintenance arrived there. But that was an imminent danger situation, but still we didn't need to use restraints. Less restrictive interventions. When I started my nursing career back when I was a psych tech many years ago, we used to bribe the patients with cigarettes. I'm not proud of it, but that's how we used to intervene. More recently, coloring books, fidget toys, stuff like that to distract the patient and get them to focus on their feelings are a way to prevent the use of restraints. And if those things aren't planned for or considered, it's a failure of treatment. We can go to the next one. I'll give you time to read that a little bit because these are things that are universal in any training that any staff member is receiving about de-escalation. In each of the 2 cases that I recently was involved with, these techniques were not used. They hadn't been taught properly, and they were part of the breach of standard of care. The biopsychosocial assessment is a comprehensive approach to understanding an individual's, I'm sorry, Ginger, you can go to the next one. A biopsychosocial assessment is a comprehensive approach to understanding an individual's health and well-being by considering the biological, psychological, and social factors impacting their condition and care. Each of these areas plays a role in shaping our experiences and influencing our health. It includes treatment history, leisure activities, spirituality, abuse history, physical, mental, and sexual, living conditions, everything that could impact a patient. Diabetics, have they had feet care? Are their blood counts off? What could prevent the use of restraints later on by addressing it now? We can go to the next one, Ginger. The clinician must use his or her expertise to evaluate and interpret the information gathered. The implications of all of this for the interdisciplinary team in providing support and education will be the most helpful way that the client can regain hope and continue his or her journey of recovery. A lot of times, especially when staff isn't well trained, they are more interested in getting the patient to do what the staff have determined what they should do, rather than ask the patient what they wanted and to work toward their goals, which just leads to a power struggle. We can go to the next one, Ginger. Each problem identified in the assessment has to be addressed in the treatment plan. Many times, problems such as anxiety, depression, weight loss, toenails, and testicles are identified in the assessment and then not included in the treatment plan and are never addressed by the interdisciplinary team. And I know I've been saying it, but again, the last two cases I was involved with, testicles actually did become a factor in the treatment and was an agitating factor for the patient that nobody on the staff had considered. We can go to the next one, Ginger. So in this next slide is the elements of performance and the standards from the Joint Commission. The most commonly used intervention, patient will attend and participate in group activities, lacks specificity, sorry. Each goal must identify specific techniques that the staff will use, how often they will be used, which staff will be using them, why this will be effective for the patient, and then afterward has to come back and say whether or not the patient did make progress. Many times, and in fact, every case I've been involved with in my career as a legal nurse consultant so far, there has not been any progress reflected in the progress notes. And the patients just escalate and escalate and escalating. And you can see that the staff is building their case for why they had to use restraints, but they don't mention any interventions to prevent them. Ginger, if you wanted to take a little, no, it's fine. I'm ready for the next one. Each goal must be a SMART goal. SMART meaning specific, measurable, achievable, relevant, and timely. You will see, because many medical people say it all the time, patient will comply with treatment. Patient will comply with groups. I always told my staff that we are not in the business of getting people to comply or make them listen. We're in the business to help them find hope and recovery. And you can't do that with people, especially people from environments of trauma. They're never going to just comply. And so that's an unrealistic goal and a treatment failure. Ginger, to the Joint Commission Standard CTS 030103. This standard is different, not different. This standard is difficult to implement in any facility, because it says when any significant negative clinical events happen, such as the use of restraints, that the staff has to go back into the treatment plan and update it to reflect the new stressors and the new interventions. I can promise you that 75% of the time that doesn't happen. And in fact, in one case, I had another nurse executive argue with me that it was impossible for it to happen. But the standard requires it. All Joint Commission standards, as you know, are in alignment with Medicare standards. So it is an absolute requirement always, and no one wants to, and most people don't do it. The initial treatment plan when a patient is admitted has to be completed within 72 hours of admission. The written comprehensive treatment plan has to be updated every 5 days or more frequently. That is in the standards, despite what anybody else tells you. Implementation of the treatment plan intervention should be clearly documented within the progress notes, stating in the note whether a problem number was discussed isn't satisfactory. The actual behaviors must be defined by describing the behavior or using the patient's quote. All right, Ginger, we're on to quality assurance. Peer review requirements may be found in the medical staff bylaws, not necessarily in the general policy, but every facility is required to have quality assurance. Generally, meetings, they have to have minutes. Generally, if the hospital uses restraints, the restraints have to be on the agenda each meeting. Ginger, we can go to the next one. These talk about litigation or legislation around restraints. On January 29th, Act 194 became effective in Pennsylvania. And in New Jersey, they have also launched an online registry that helps staff coordinate with the patients about their advanced directives. The passage of this legislation is largely a result of collaboration between advocacy organizations, county governments, professional associations, and the state government. Pennsylvania is pleased to join the national trend of promoting the use of the advanced psychiatric advanced directive as a tool in mental health policy and the prevention of the use of restraints. An advanced directive can include a power of attorney where the individual authorizes a designated mental health care agent to make treatment decisions on his or her behalf in the event of a mental health crisis. This guide, which outlines an agent's responsibilities, has been developed to assist in serving as an individual's mental health care treatment advocacy tool. Essentially, it allows planning ahead for mental health services and supports needed techniques in a crisis before the actual crisis occurs. All right. All right, Ginger, we're up to the regs.
Yep, this is perfect.
All right. Did you want to take a break here?
That would be wonderful. We'll take
I would love that.
we'll take just a quick break right now. And what I'm going to do is bring in some of our amazing partners real quickly. We've got Cody coming in from Fox AE, and then also I have got Laura coming in from HMR. So let me bring them in real fast. And
Thank
then
you.
also, this is a good time if anyone has any questions about all the things that Teresa's been discussing. Please go ahead and put those in the Q&A box, and we can ask them your questions afterward. But this is all super interesting and fascinating. So thank you for covering it, Teresa.
Am I going too fast?
No, this is great. And I'm excited. We've got Cody coming in today. Cody, it is great to see you. I know I'm going to see you in a couple months because we've got our Nashville seminar that has launched. And I hope you guys have had a minute just to look at the agenda. If you go to connectionology.com, you can take a look at the TBI seminar that we're doing along with pain, suffering, damages. And we're covering a lot of new stuff this year. Got some great speakers and very special events. We're doing things that I have not seen anywhere else. So it's going to be a lot of fun. And I'm glad you're going to be with us, Cody.
Oh yeah, and really looking forward to that event. Actually, we're planning it out and planning it out now. There's some surprises. So first of all, happy Valentine's Day to everybody.
Yes.
And Ginger, thank you. Can't wait to see you as well. And Nashville is going to be a blast. So if you don't know, we do science and engineering graphics. And so a lot of that has to do with medical graphics and things like that. And so we can do, we do a lot of high profile stuff, but we also can do medium-sized cases as well. And so I want to show you where graphics doesn't have to just be used on a $1 million to $50 million case. It can actually be used for scenarios where you just want to get the point across and maybe solve this in mediation or something like that, right? So as a quick example, for $1,000 to $3,000, you can actually get a demonstrative exhibit that you can plop on a board and print out and things like that. And it shows damages. It shows injuries. You've got bone bruising here, meniscus tear, cartilage injuries. And so what's not noticeable on, you see the black and white images there, the MRIs, CTs, X-rays, in this case, MRIs, you know, it's really hard for the jury to envision that. And for many people, even people who've seen injuries all the time, you know, sometimes if you're not a radiologist, it's difficult to pick up. So having these three-dimensional demonstratives and things like that is an inexpensive way to just bolster your case and really communicate the injuries. Because a lot of times, you know, the argument is, oh, this is just frivolous. It's just frivolous. And so show them that it's not. And so that's what we do.
Fantastic. And I've seen some incredible images and graphics, all the things that you guys can create. And it blows me away every single time, Cody. So you got an amazing team. You know, John Romano, we all love working with you. So I'm sure everyone watching has already saved your information, but if we have any new viewers that are with us today, Cody's going to put his information in the chat box. Highly suggest that you save it. Keep it on speed dial. Thanks, Cody.
Thanks, Ginger.
All right, we'll see you back here again very soon because we have some more webinars coming up that I will be launching on our website. But thank you for being with us and happy Valentine's Day to you too.
See ya.
Now I see our good friend Laura is with us with HMR. Laura, I'm so excited you are joining us again. Thank you for taking the time to be with us. HMR has been incredible to work with. So I can't wait to hear some of the great things you guys will be sharing about all the things that you guys do over there. So please, you know, go ahead and share that. We're just happy to have you with us.
Thank you so much. It's great to be here on Valentine's. So what a treat. For those of you who may not know HMR Servicing, we are a national funding program. We're in 39 states nationwide. We offer some valuable services for your personal injury cases. First and foremost, I would say, is our medical funding. We're able to look at your case from the minute you send it to us, roll up our sleeves, underwrite it, and find out first what is needed, what is the care plan that is required. We approve that in real time. We work with you to get those appointments scheduled, get those, you know, those much needed medical appointments to find out what is going on with your client medically. In addition, we are able to help with any cost of living needs that may be a problem. Maybe your client isn't able to work. In serious injury cases, we always see assistance is needed for those monthly bills, for car payments, for mortgage. I have a case right now where we have been funding the medicals for over a year, and now at this point, we're trying to help this individual keep his home and keep his car so that he can actually get to his doctor's appointments and continue his treatment. For you, the attorney, we're also able to help you with those expert funding needs. It could be that you need graphics, you need reports, you need experts, all of those things. We're able to help you as you prepare your case for trial or for settlement to make sure that you have everything that your client needs so that you can build those damages, prove the injuries, and then also go through to the final moment if you're going to court to make sure that you have what you need for that preparation as well. We are not just one person. When you work with us, you get an entire team. I would say that is our best feature. From the moment you send us your case background information on our website at hmrservicing.com, we are underwriting your case with a team. Our case managers are rolling up their sleeves to find out how to schedule who, all of the things to keep you aware of what we are doing from moment to moment. And then, of course, our administrative team is there towards the end of your case to help you as you're trying to resolve your case, whether it's settlement or whether you have, you know, you've truly won your case in court. So we're there from start to finish. I'll put my information in the queue. We welcome any questions you have. Underwriting is free. A lot of times people just call and want a second look at their case before they submit it to us. And we absolutely love that. We have an entire nationwide group of business managers who can help you in your state. And we're just here to help. So thank you so much, and enjoy the rest of the webinar.
Fantastic. Thank you, Laura. And again, you guys, she's going to put her information in the chat box. So please save it and reach out to her if you have any questions. We think the world of you guys and your company. So thank you for all that you do. And I know that we're going to see a lot of your team members in Nashville soon.
Yes.
Huge thank you for being involved with that. So we're going to have a good time. Thank you.
Be safe.
All right. We'll see you soon, Laura.
Thank you.
All right. And now, Theresa, I saw that a question has come in.
I'm excited about it.
Yeah, let's see. And guys, please feel free to ask your questions if you have any. We'll be doing this again towards the end of the webinar. Miss Stacy wanted to know, I don't understand how you can use AMA judiciously if the patient is in their right mind and has the right to refuse treatment. Is there any explanation to that?
So I would not dare to try to give any legal explanation to lawyers. But what I will say, what I say to my staff. So if the patient comes in and is admitted with all of these, you have to meet criteria for admission and to be able to be paid for treatment. So whether they're in their right mind would be based on your assessment. So if you do an assessment that says the patient needs such and such and so, but our program only offers this, that, and the other thing, so we didn't do the such and so, and we didn't listen to what the patient wanted, and we didn't listen to what the patient needed, and we didn't really hear all the underlying medical conditions or the family situation, and now the patient is freaking out and walking out the door, I think that you can very easily link your failure to properly assess and plan for and treat the patient with the fact that they left AMA. And now we know that patients that are being treated for opioid use disorder have a 30% chance of overdosing and dying the minute they walk out the door. So you have to take every action you can to prevent that from happening, from engaging the patient into the kind of care that they're looking for. I also think that after the AMA, when the patient leaves, it is a requirement of most insurance companies, and I'm not sure where ASAM stands on this, but most insurance companies say you have to reach out, you have to make sure they're safe, you have to make sure they have follow-up care before they even go out the door or immediately after, and then report it back to the insurance company. And a lot of times that doesn't happen. So that's my stance on it. Probably if I thought about it further, I'll have a lot of, that's what I should have said afterwards, but that's what I have for now.
Oh, perfect. And I was going to say, if anyone has any more questions, definitely, I put your information for email in the chat box. So please reach out if you want to discuss a little further. But for now, I'm going to go ahead and go back to the slides. How's that sound?
That sounds good. I did want to mention a couple things. First of all, Cody, I wanted to thank Cody for I was so excited for the GIFs to be on the slides, and then Cody came with that drawing, and that was absolutely amazing. I was very impressed, and I just wanted to say that out loud. And having done 1 or 2 life care plans, also HMR, the work that they do is absolutely incredible and very difficult.
I tell you, we are so lucky at Connectionology. I mean, HMR, OnPoint, you know, it's, I don't know how to explain it, but we are so fortunate. We're such good groups. And I've been doing this a long time. I've worked with a lot of groups around the country, and I'm a little biased, I guess, but I will say we've got some amazing people that we work with. So
really do.
Thank you for saying that, Theresa.
Yep.
All right.
Okay. So the regs, these are the CMS regs. The guideline 483.13, we're to, are we to RBG? This
yes, we are.
Okay. Again, it's a review of the definition of physical restraints, chemical restraints, and this was a big deal when the CMS changed this regulation, and it's at least 15 to 20 years old, but still it isn't complied with a lot, where physicians will use PRN medications, as needed medications, routinely. We consider that the federal government considers that a chemical restraint. So if you see that a patient is getting the same med over and over again every 6 hours, that's not a PRN, that's a routine chemical restraint. Restraints may not be used for staff convenience. We can go to the next one, Ginger. However, if the resident needs emergency care, restraints may be used for brief periods to permit medical treatment to proceed unless the facility has a notice indicating that the resident has previously made a valid refusal of the treatment in question. If a resident's unanticipated violent or aggressive behavior places him or her in imminent danger, the resident does not have the right to refuse the use of restraints. In this situation, the use of restraints is a measure of last resort to protect the safety of the resident or others and must not extend beyond the immediate episode. The resident's guide to participate in care planning and the right to refuse treatment are addressed in guideline 483.20. And this lady, I saw her many times. I worked with her for years. Next one. New Jersey Department of Health regulations on restraint use in behavioral facilities focuses on minimizing restraint use and prioritizing patient safety and autonomy. Prohibition of routine restraints must be used in all policy development. Every restraint requires thorough documentation, including the reason, alternatives attempted, monitoring and review, and staff training. We can go to the next one.
Okay, this one's the Keystone State. Is
Right.
that right? Okay,
Yep.
perfect.
So only licensed or qualified staff trained in restraint principles and techniques can apply those restraints. Generally, the hospital policy will require that to happen every 2 years. I think regulations, I mean, the hospital policy will always be every 1 year. Regulation, I think, says 2, but you would defer to the policy. Only physicians or qualified mental health professionals can order restraints. An RN can initiate restraints in an immediate danger, but then has to call the doctor and get orders, and the patient has to be seen within the hour. You cannot use restraints for punishment, convenience, or staff safety. Patients have the right to be informed about the risks and benefits of restraints and to refuse restraints except in emergencies, and have a right to grievance procedures. We can go to the next one. So I don't know, many of you may or may not know, but Philadelphia, as of 10 years ago, was the only city who had a system-wide recovery-oriented care system, Connecticut being the only state, and that was under Dr. Arthur Evans. And what this means in the use of restraints is that it's expected there be transformational leadership and recovery-oriented care, which requires, again, individualized, and that you be in partnership with the patient and not the medical expert. that determines their care, but helps them to determine their care with your expertise. That was the Philadelphia DBH-IDS one, Ginger. And now we can go to the Nurse Executive Advanced slide.
Got it. That's perfect.
So earlier on, I forgot to tell you a little story, which I want to tell you now. And that's why this slide is here. When I first became a nurse's aide, I was like 19, 20 years old, and I got pulled to the psych unit at Metropolitan Hospital, which is in Center City, Philadelphia. And it's right across the street from the Roundhouse, which is the police station. And so all the prisoners and stuff would come over. And my very first time on a psych unit, I walked into a room where a patient was restrained. And in those days, you could still restrain them with chains on the floor. And he was. And I walked in and he was crying and begging for help and screaming and hollering. And when I walked in, the other tech took a mop out of a corner bucket in the corner of the room and took the mop and put the mop on the patient's face. I wasn't very well versed in hospital politics at that point, and I ran out and made a big stink about it, which I don't regret, but I did at the time. In any case, that incident taught me that I needed to be more in power of what happens to the patients around me. And that's why I chose the career path that I did. And that's why explaining to you what a nurse executive does, and why they're so responsible in this, because often they get left out of lawsuits. And I know I shouldn't be the one saying it, but I am, that they have a big responsibility. I had a big responsibility in this, and that they absolutely can make difference through policies in the use of restraints. Okay, we can go to the next one. This is the Joint Commission. Again, some of the standards that have to do with nurse executives. I'm not going to read them all to you, but I did want to make everyone aware that there are specific standards about what the accountability and responsibility of a nurse executive is. Word to Madam Secretary, Ginger. Again, this just goes on to talk about that the nurse executive has to have the education, experience, and qualifications. A nurse executive has to have a master's degree, unlike a director of nursing in a nursing home who only needs a bachelor's degree. The nurse executive has to have the authority and resources necessary to fulfill his or her role. That again is a very frequent problem, and requires a really in-depth dive into the records, and not just the patient's records, but the hospital records, to make sure that the tools and knowledge were in place to carry out the requirements of the policy. Which brings us to policies. We can go to the next one, Ginger, which says policies.
Okay, great. We're on it right now.
All right. An educated and implementable summary of all applicable expectations of the hospital and its staff. It also establishes specific expectations for employment competency assessment, performance appraisals, and accountability in disciplinary procedures. Relevant restraint policies would include the codes policy, emergency, that's the emergency situation, who calls a code, how it gets called, who shows up. The audience in a restraint event is a very big deal. The assessment policy, the treatment plan policy, and the policy. So there should be a policy that says who's responsible for writing the policies, who's responsible for reviewing, how often, which requirements are required to be in there. Every case I've had as a legal nurse consultant was lacking in the required policies. And the Joint Commission doesn't cite you on not meeting their regulation. It cites you on your policy not meeting its regulation, or you not meeting your own policy. I hope that made sense. The policy, another policy that would matter is how we approach patients in a trauma-informed environment, the documentation before and after, and what special precautions look like. Like if you have a patient on monitoring, which 9 times out of 10 before restraints, the patient will be on a Q15 or a 1-to-1. If they're on those monitorings, what are you looking at? How long do you have to look at the patient? Do you have to look at their chest to make sure that they're breathing? What has to be reported to a nurse and what doesn't? Okay, we can go to the next one. All policies have to have the guiding principles, again, of the least restrictive environment, patient choice and autonomy, therapeutic relationship. And that therapeutic relationship matters a lot. Back in the olden days, you would just tell the patient, come in, sit down, be quiet, or you're going in restraints. Now you have to engage the patient. That takes skill and certain techniques such as motivational interviewing to make sure that you're doing it in a way that's helpful to you and the patient and the environment. Continuous monitoring and evaluation. Again, if the standards aren't standardized across the country, which they are not, then each hospital has to have the same standard for everybody in that system. Documentation, staff training, and education. I know it's kind of a repeat, but you'd be amazed that people just don't do it. Policies include specific procedures for applying. Oh, we can go to the next one, Ginger. Oh, it says procedures on the top. Policies. Okay, good. Specific procedures for applying and removing restraints. Like you should do one arm and one foot, and then the other arm and the other foot. If your policies don't say that, the staff doesn't do it, and then the patient gets hurt, your policy's the problem, not your staff. We can go to the next one. Policies must be readily available to all staff and patients in clear and accessible language. When I started my career, there used to be like 5 huge 6-inch binders across the nurse station calendar. Now it's usually on an intranet. And I will I'm not reading all my notes to you guys. I'm sure you're very relieved to hear that, but I'll include that with any slides that I send out. We can go to the next one, Ginger, which says continuous improvement. Contracts with insurance and managed care companies provide further accountability matrices and pay for performance criteria. Probably I could go on about that for quite a few minutes, but I won't. Third party, oh, we can go to the next one, Ginger. Third party evaluations and monitoring. This can help an independent perspective, add an independent perspective as mandatory part of mandatory risk management, performance improvement, regulatory survey readiness, and or the plans of correction afterward. So much to my surprise, after I got my CLNC, I had a couple people reach out to me from both nursing homes and hospitals to come in and look at some of their quality improvement stuff around trauma-informed care, recovery-oriented care, and restraint prevention. we can go to the next one, Ginger, which should say related litigation. And I'm not going to pretend that I really knew anything about these cases before I looked them up for this presentation. And thank you to Bard for this. All right, Ginger, you can go to the next one. So as I was developing this presentation, staff member that I worked with for about 15 years and who I almost fired when I first became his boss, found out that he had terminal cancer. I put this slide in there because he is in 12-step recovery, and his whole thing was getting patients, whether psychiatric or substance use disorder or both, to just listen to what I say. And I had to call him in my office like 12 different times because his heart was so good, but the language that he used just kept provoking patients. He was my biggest lesson in transformational leadership and accountability. And I wanted to honor him with this slide and to inform all of you of the importance that language plays, especially in trauma-informed care environments. And after that is the references. That's all I have. I'm happy to answer more questions or chat or let you go early, whatever Ginger says is the right thing.
No, this is great. And I just wanted to remind everybody, first of all, thank you for that last slide about Carl and sharing that story as well, Theresa. I know that he's going to be definitely in our thoughts.
Thank you.
If anyone has questions, now's the time. I'm going to look and see if we have some right now, but also just a reminder that you can email Theresa and she will be able to send you a copy of these slides. But also there is just a huge variety of other topics, especially around mental health, that I want to cover with you. Like I said, we can go on because we got a lot we're going to talk about. But I just want to thank you so much for being here with us today to discuss this. It's an important topic, and I appreciate that.
Thank you.
Absolutely. All right, let's see if I've got any questions real fast. Some very kind comments. Thank you so much, Ron. He said, this is an incredible seminar. I hope a video can be available for future review. Yes, we did make a copy of this today, and we should be adding it to our YouTube channel. You guys can also go to Connectionology to our YouTube channel and view some of our other webinars as well. And then just keep an eye on the website because we will be uploading a lot of new ones coming up soon. If you know anyone who would like to speak, including yourself, contact me because I am working on our schedule through June, as well as planning our live seminars as well. So thank you for all these sweet comments, you guys, so much.
Yes, thank you so much. I was so nervous. You guys made me feel so much better. Thank you.
No, don't be. I tell you, it's just such an honor to have you with us. And I know that Ted wanted to be here with HMR because he does our coffee giveaway. And he is out doing some Valentine's Day things. However, he gave me the name of the winner. So I'm excited to share who the winner is of the HMR coffee giveaway today. And I'm even more excited because I do know this wonderful attorney. So congratulations to Miss Sandy Van out of Las Vegas. She's a great attorney. She's actually come to a lot of our seminars before, it's Theresa, and I've met her. She's amazing. So congratulations, Sandy, well deserved. And don't forget, guys, that if you didn't win today, there's going to be plenty more chances. I know we've done, I think, over 350 some different webinars. John Romano is still trying to win, but we will be having him with us shortly. I actually have another amazing webinar with John coming up in a week or two. We're going to be talking more about radiology. We've got this whole radiology series, which is very cool. But Theresa, I hope that we have you back with us very soon. Thank you for being with us. Do you have any closing comments before we head out today?
I do not. This was a great opportunity, and I'm glad to get the information out there. Thank you for having me.
Well, thank you for all that you do, and thank you for helping educate a lot of our attorneys and get the word out about these important topics. Thank you for helping your patients, and I just blown away by everything that you do. So thank you. And for everyone watching, happy Valentine's Day. We love you guys. And we will see you back here in another week. But enjoy the rest of this afternoon with your family, your loved ones. And thank you again for watching today. Bye.
Thank
everybody.
you.
And also big thanks to, again, our amazing partners at HMR, OnPoint, and Fox AE. You guys are amazing. We will see you again soon. Bye, everybody.
Thank you.